Hi,
Mhm.
everyone. Thanks for joining today. This is Get Madhu Mesh Community Network, sponsored by Madrigal. My name is Valerie, Shin, nurse practitioner. I work at UCLA Health in Flagler Liver Institute. We're located in LA, California. This is a QR code to register for this meeting, but I believe all of you already registered and that's why you're here. But if you're sharing the screen with someone else, please be sure to register. This is like your attendance. Okay, I'll leave it for like 5 seconds. Okay, so today we'll cover MASL and MetALD. This is part of MASL Mesh Community Network Education Series. We're gonna start with a case. Ashley is 52-year-old woman and who was referred to our liver clinic after an abdominal ultrasound that showed enlarged liver, which is just mild, and increased hepatic ectogenicity consistent with steatosis. She feels fine and she has no other complaints at this time. Her past medical history includes PCOS, high blood pressure, high cholesterol or hyperlipidemia, overweight, and her BMI is 29.4. She does have metabolic disorders, as you can see. She says she drinks about average 2 glasses wine a day is average, probably a little bit less, a little bit more, but average. Her physical exam of the liver was unremarkable. Her medications include amlodipine, statin, multivitamin, and milk-cecil. I wonder why she's taking milk-cecil. As you know, milk-cecil often advertised as a liver supplement. I wonder if she knew about her liver disease for a while, maybe a few years. I'm just assuming. And we'll move on. Her vital signs, blood pressure 140 over 78. Her systolic blood pressure is somewhat elevated, right? So I wonder if her blood pressure is well controlled at home, or did she forget her morning mass today, or this clinic visit made her anxious? Her liver tests are elevated. I mean, it's not super high, but it is definitely not normal. All ALT, AST, alk phos, total bilirubin. So based on history that we know of, the liver test elevation can be from the liver fat or alcohol, or she's taking milk cecil. So I wonder drug-induced liver injury can be part of this, or can there be something like totally other chronic liver condition? So Ashley will definitely need full workup for abnormal liver test. Her platelet looks good. So just looking at her platelet, there's no strong evidence that I can say, oh, she has liver cirrhosis. Not like that. A1C is 5.9, which is considered as prediabetes, and this is in addition to her other metabolic conditions. Her triglyceride is over 150, so it is elevated. And if you recall, she is taking statin. So Ashley had a full liver serology workup and then were unremarkable. Okay. And then for the next step, we do want to stage the liver. This patient had non-invasive testing, the transient elastography or FibroScan, which I think it's suitable next step for staging her liver. If you're like, what is she talking about? What is FibroScan? Then we have other lecture or education series on our website, so please check it out. So based on this FibroScan, she has 11.4 kilopascal, which correlates to F3 fibrosis. And patient's CAP score is 310, which suggests severe steatosis. One thing I wanted to point out about FibroScan, so it depends on which etiology you enter, the result can mean something totally different. I mean, even if it's the same number. Like for example, her CAP score is 310, right? But if we just enter the MASLD etiology, this 310 means moderate steatosis. But in Ashley's case, I believe we enter multi-etiology, which is steatosis and alcohol. So this 310 actually falls under severe steatosis. So please do remember the reference range for the FibroScan result is not just one and done. It varies, depends on the etiology you enter. So she has F3 and S3 or severe steatosis. Okay, this is a fun slide. This slide has been frequently presented in the liver ward this year. We have a new recommended term for fatty liver. This is now steatotic liver disease or SLD. This was considered because its new name is more accurate and less stigmatizing. So let's take a look at the subtypes. MASLD is replacing the old name NAFL, non-alcohol fatty liver disease. We learned that a majority of the patients who are in NAFL group had metabolic disease, so this name change makes sense. And MASH is metabolic dysfunction associated steatohepatitis, previously called NASH. So if you see NASH, it probably means MASH. It is the inflammation of the liver fat, basically progression of MASLD. Then we have MetALD, which is the mixed etiology of steatosis and alcohol use. And there is ALD, alcohol-related liver disease, which is heavily due to severe alcohol use. So some providers ask, like, how do you differentiate between MASLD, MetALD, and ALD? And I explained that this is mainly depends on the patient's alcohol consumption. In the US, one standard drink contains about 14 grams of pure alcohol. So daily intake of like 20 to 50 grams for women, which is like 1.5 to 2.5 drinks a day, and 30 to 60 grams for men, which is 2.5 to 4.5 drinks a day, is classified as MetALD. So anything less should categorize as MASLD. Anything more should categorize as ALD. If it's easier to calculate the weekly alcohol intake, it's on the slide. It is between 140 to 350 grams for women and 210 to 420 for men. So within this subtype, the lower amount of alcohol, we call it MASLD predominant MetALD, and the higher amount of alcohol consumption, we call it ALD predominant MetALD. And then the steatosis also can come from the other etiologies, such as drug-induced liver injury, Wilson disease, environmental toxins, HIV, and others. And today we'll focus on MASLD and MetALD. This is a standard drink chart. Alcoholic beverages come in different size glasses and types, but each of the drinks shown here are all one standard drink. So meaning they each contain 14 grams of pure alcohol. So numbers at the bottom of the chart indicate the alcohol content per drink. The smaller servings are typically contain higher alcohol consumption or alcohol concentration, regardless of the type or brand. And what defines the standard drink is the amount of pure alcohol, not the volume, not the container. And this one slide is a useful tool to help us accurately estimate a patient's alcohol intake. So I have a little magnet in my clinic, which is just like that to calculate how much a patient exactly drink per day or per week. So patient, they report how many drinks they drink, but as a provider, it is important to consider both the size and alcohol content. I'll give you an example. So the first one is a 12-ounce beer can, right? And then at 5% alcohol by volume. That counts as one drink. But let's say it's the same 12-ounce beer can, but if it contains 10% alcohol by volume instead of 5, it actually contains as 2 drinks. So again, depends on the size and then alcohol content percentage, it makes a difference. This diagram shows how two etiology liver disease, steatosis plus the alcohol, are connected through changes in the gut microbiome, which together speed up the liver damage. Let's review the risk factor for MASLD, and I think we have reviewed, which is insulin resistance, diabetes, obesity, visceral fat, unhealthy food, sedentary lifestyle, genetic susceptibility, epigenetic factors, plus the alcohol use can impair the lipid handling. This leads to oxidative and endoplasmic reticulum stress that leads to cell death. And this type of stress also disrupts the gut microbiome, cause to produce harmful substances like ethanol, lipopolysaccharides, and other byproducts. And these substances together trigger the inflammation in the liver, and ongoing inflammation speeds up the liver scarring, which means fibrosis, and drives the progression of the liver disease. the drivers of liver disease. This slide shows the estimated 5-year risk of decompensation between MASLD, MetALD, and ALD. In brief, the more fibrosis a patient has, the more alcohol patient consumes, the higher the risk of decompensation. For example, in patients with advanced fibrosis due to alcohol liver disease, the estimated 5-year risk of decompensation can be as high as 50%, 50. That's pretty high. Please note that there is a genetic factor plays a role in developing steatosis. For example, PNPLA3 is a generic variant that is more common in Hispanic individuals. They tend to accumulate more fat in the liver. It does not act alone though, but with obesity, insulin resistance, type 2 diabetes, dyslipidemia, high blood pressure, in addition to alcohol use, can worsen the outcomes in carriers of the variant. Detection of alcohol use with biomarkers. So if a patient tells you that he or drinks like 1 glass of wine daily, would you just go with it? Would you just trust them, or you actually check the biomarker? I would check the biomarkers. How do you detect the alcohol use with biomarkers? The first column in this slide showing different risk factors can develop steatosis, which we have reviewed already. The middle column is showing the examples of alcohol tests. This includes audit questionnaires, and different tests include blood, urine, and hair alcohol tests. I actually never done hair alcohol tests, but that's one type of test. The last column presents findings from a study that the results reveal that alcohol use is often underestimated among patients in MASLD group. That is, we often assume that alcohol is irrelevant thing in MASLD group, right? But this study found about 30% of non-alcohol fatty liver group show signs of moderate to severe alcohol consumption. And what does that mean? That means we underdiagnose patients. So these MASLD patients supposed to be categorized as like MetALD and ALD, not MASLD. So as a provider, it is super important to thoroughly assess patients' alcohol history and give them the right diagnosis. Is it MASLD, MetALD, and ALD? Our patient Ashley had a type of biomarker as well, but this one's called PATH test. We haven't reviewed that yet, but we will. Her number shows 120 nanogram per liter. This correlates to moderate to heavy alcohol consumption. Did she say she drinks about 2 glasses of wine daily? Maybe she drink a little bit more than that. Okay, let's talk about the PATH test. I like PATH test, and I use it often in the clinic to detect the alcohol consumption level in patients. It is especially useful when a patient's self-reported history may not be so reliable. PATH or phosphatidylethanol ethanol is a direct biomarker of alcohol that forms in red blood cell membrane when someone consumes alcohol. So if patient had a CBC in the blood draw lately, then you can also send the PATH as an add-on lab. If it's an available option, then you can save a poke from a patient. It is specific to alcohol with very high sensitivity and specificity. The downside is the result can take up to 3 to 5 days from the date of blood draw, so you gotta be a little patient. Ashley's PATH test is 120, which falls into MetALD category. You know, sometimes I have to face the patient who says, I don't drink alcohol, but PATH test is positive, especially with like liver listed patient. False positive PATH test is really rare, and I looked it up. It is really rare. Some argue, like I use the mouthwash that's alcohol-based or ethanol-based cough syrup, but usually it really does not detect the level. PATH is a highly reliable test. So if it's positive, that probably means patient consume alcohol. Okay, more about PATH. The first image here illustrates the behavior of PATH and blood alcohol concentration BAC test over time following a single binge drinking event. Blood alcohol concentration peaks around 2 hours after drinking and then drops rapidly and clear after 8 hours. the path is a blue line. It starts lower than blood alcohol concentration, but gradually increase and plateau around 6 to 8 hours. Then it kind of remains elevated much longer, up to 2 to 4 weeks. Path can be detected for 3 to 12 days after one single binge, meaning one time or low-level alcohol consumption can detect about 3 to 12 days. But in real-world cases, like involving regular or chronic drinking that like we see a lot in our clinic, path can indeed detect up to 3 to 4 weeks. But exact window depends on the amount of alcohol consumed, frequency of drinking, individual metabolism, and then the right side of slide explaining that there was no difference on path test between men and women and also different BMIs. This is a study looking at the alcohol use in individuals with increased weight. The result shows about 15.7% of people in this group are at risk for MetALD based on alcohol consumption history and path test. Okay, let's go back to our patient really quick. I would like to emphasize that our patient actually has metabolic disorders, including PCOS, which is highly associated with steatosis. And she also has high blood pressure, high cholesterol, and overweight. And also she had prediabetes, right? Her A1C was elevated. So let's keep that in mind. And let's review the relationship between alcohol and high blood pressure. Let's say you're seeing a patient in the clinic for steatosis evaluation, and during the visit, you saw one elevated BP reading, and patient has a history of high blood pressure. So it's either BP not well managed yet, or did this person miss the morning dose of antihypertensive, or patient denies having high blood pressure. He's not on any blood pressure pill. Then is this a white coat syndrome? Did the clinic visit made him anxious? So we can think about all that. But here's where it gets a little interesting. So one systematic review in 2020, 32 randomized controlled trial involving nearly 800 participants showed that alcohol has a biphasic effect on blood pressure. So in the first 12 hours after consumption, alcohol can decrease the blood pressure, but after 13 hours, blood pressure increases. So now when a patient present with hepatic steatosis and a single elevated blood pressure reading on vital sign check, don't dismiss it. Take a detailed alcohol history. What looked like MASLD could actually be MetALD or even ALD. And now we'll look at the relationship between alcohol and hypertriglyceridemia. Oh my God, it's hard to pronounce. Triglyceridemia, okay? Similar to the previous slide, this study examined the mean plasma triglyceride concentration over 10 hours period after consuming 2 standard alcohol drinks versus water. So the findings showed that individuals who consumed 2 standard drinks had consistently elevated triglyceride levels compared to those who drank only water. And this was true regardless of whether they had underlying triglyceride elevation or not. So if a patient has, if they present with an isolated elevated triglyceride level, it may be a clue that they're consuming more alcohol than they report. So don't overlook it. A thorough alcohol history is very, very, very important. So let's put everything together. So this is 52-year-old Caucasian woman, a woman with the abnormal liver ultrasound consistent with steatosis and elevated liver enzymes, right? In setting of PCOS, high blood pressure, hyperlipidemia, prediabetes, and overweight, all the risk factors for cardiometabolic risk factors. Based on her FibroScan result, alcohol use history, and positive path test, the most likely diagnosis is steatotic liver disease. And there's a subtype, right? We think this is MASLD predominant MetALD with advanced fibrosis because she had F3 fibrosis on FibroScan, right? Okay. So we still have questions to answer. What are the current treatments? All patients with hepatic steatosis, and regardless of etiology, they should be counseled on like heart-healthy diet, Mediterranean diet, and weight loss. Usually for weight loss, depends on their weight, right? I usually recommend 5 to 10% of a current body weight. That should be their goal over a long time, like 6 to 12 months, and to maintain the healthy weight. Is she a candidate for resmetirom? So I wonder what other provider will say. I'll tell you what I think. So resmetirom is indicated for F2 to 3 MASH patients, right? But resmetirom is not indicated for alcohol-related steatohepatitis. The MAESTRO-NASH trials exclude the people who had a significant alcohol use, and that is a man drinks more than 2 a day, and women drinks more than 1.5 a day. So to me, I first recommend Ashley to stop drinking alcohol before to be considered for resmetirom. Because if she keeps on pouring alcohol while on the medication, it is not the right way to utilize the medication. When patient takes resmetirom, they're strongly recommended to follow healthy lifestyle changes, which actually includes no alcohol. So she should stop drinking alcohol first, and after time, then we can consider resmetirom. So other question is, what are your recommendations regarding alcohol use and what do you think? The answer is no. There's no safe amount of alcohol in patients with chronic liver disease. No alcohol. And the other question is, does she need HCC surveillance? We know for a fact that if someone has truly a cirrhosis, we do HCC surveillance every 6 months routinely. But what about F3? She had F3 fibrosis, right? I consider that advanced fibrosis. I'll still do ultrasound and AFP every 6 months, just like F4. Okay. An ideal definition of MetALD for clinical trials should incorporate both alcohol consumption and metabolic dysfunction. Objective biomarkers should be used to overcome underreport of alcohol use, to standardize the assessment of recent alcohol use, and to certify alcohol abstinence. Ensure that drivers of liver disease are present, consider more than one cardiometabolic risk factor, or ensure persistence of high blood pressure and high lipidemia after stop alcohol use. Consider exposure to risk factor, fulfillment of criteria during the last 6 to 12 months. Okay, let's repeat the take-home messages. The definition of MetALD is weekly alcohol intake between 140 to 350 grams for women and 210 to 420 for men. Clinical criteria could underestimate MetALD. Therefore, utilization of alcohol biomarkers should be considered, like PAT test. I love PAT test. And then ensure the driver of liver disease and consider adequate exposure to risk factors. Look at the previous documents to see the persistency of the exposure to cardiometabolic risk factors. The criteria for clinical research to facilitate an objective MetALD diagnosis, allowing comparison among different social culture realities. Okay, this is it. So please visit this QR code to learn more about MASLD MASH education series. We have a lot of them and a lot of them for fun topics. And you will also learn about resmetirom, the MASH drug. Okay, if you guys have any question, I'm open to it. You can turn on your microphone and then ask me questions.